Thank you, Madam Chair, and thank you, guys, for convening this meeting. I appreciate the charge of our VA is to take care of all our veterans and be that safety net, be there for everything. However, I just have to push back on the maligning of community care. I'm actually one of those people that has done it for 30 years. And there are two things that I think we just need to understand and agree upon. Number one is community care essentially is specialty care that the VA cannot offer. That's primarily what it is. And specialty care, by its definition, is more expensive because, guess what? Those are specialists. And they oftentimes need surgical intervention, which, guess what, is more expensive. And so just, maligning community care just because it's more expensive, you have to understand why it's more expensive. It tends to be specialty care. I'm a specialist, I'm a surgeon, I'm a specialist. It costs more when you operate on those things. The other thing is wait time. Wait time for primary care out in the community can be long now, but it's even exacerbated now because we have too few specialists in this country. So yes, wait time is longer, but it's because they are specialists. So again, when we're making this discussion, and I hate that it's a pro-con thing because I worked as best as I could always to provide our veterans with the best care. The problem is the VA never followed up. We were never sent records. We were never sent anything. It's a big black box. So it's much more difficult to take care of veterans in the community because the VA doesn't want you to. And I can understand that to a point where you're trying to provide a body of care, but the fact that the VA will sometimes just literally not cooperate at all hurts the veterans. So I think that's important. I think another thing I think that needs to be brought out is Dr. Analo had said earlier they're working on trying to get inefficiency and productivity within the VA system. If a VA doctor sees 7 patients a day when the community would see 25 or 30, that's an issue. So that's an issue within the VA that the VA needs to take care of itself. So just like many of the members of this community, on this committee, I have a ton of it. 1 out of 10 of my constituents is a veteran, and we hear the complaints. So what am I supposed to say to all our veterans who are unsatisfied with the system? That 92%, that's great. That's not what I see. And so if a veteran is referred out or doesn't get into the VA in a correct period of time, what am I supposed to say to them, Ms. Peabody? I mean, there's only so many calls and so many times that we would reach out to say, hey, can you get this person in, et cetera? What am I supposed to say that? Because please don't paint this as a beautiful picture because it's not. That's not what we hear from our constituents.
Thank you. I'd like to turn that to Dr. Scavella.
Yeah, so thank you for that question. So you've raised several concerns that we are working to address. So we are very pleased that in some areas we have done a great deal to improve quality and access to our veterans, but we do recognize that there are pockets in our system where we do need to make improvements. So you raised several concerns. One, we actually do have just under 100,000 veterans who are actually getting primary care in the local community, and I do recognize it as a specialty since I'm an internist. So that is a portion of what we're providing, but you're correct in that for specialty care, for subspecialty care, for surgical care, that is more expensive and the wait times are longer. So we do recognize that and we are working to try to address that both internally.
Nothing need to address, it's just a fact. And so when you malign the community care and saying, well, you're longer wait times, well, it's because everybody has longer wait times to see a specialist. That's all. I just want the vocabulary to be fair. That's all.
We understand that. I take that at full face value. The other thing is we do have an interoperability pledge to try to work on the issue with the medical records. Having worked in our system, taking care of veterans myself, and having patients who chose to go to community physicians such as yourself, and I was tracking down the records. I understand what that is like. So our Undersecretary for Health has entered into an agreement with 13 healthcare organizations to make sure that we are able to get those records back in a timely fashion. So we'll have those, and also to share our records with you so that we'll be able to provide that timely care. And then the third concern you've raised about pockets where we're not being as efficient and as productive. We are addressing those issues, and we definitely want to make sure that we don't have clinicians that are seeing small numbers of patients where others are seeing many large
Yeah,
numbers.
and I appreciate that. Again, we won't go back to the whole debacle, I think, of the VA's choice of electronic medical records, because I can't access any of that stuff. If they were on another system, I can access that. And I don't know how many times in the last 30 years I've had a veteran show up extremely disappointed because they got referred to me, but there were no records ever there, and I have to literally send them back to the VA when they have a cancer diagnosis. Go back, get your records, which is frustrating for me, but also infinitely frustrating for the patient, because then they got to get another appointment, et cetera, et cetera. That's something that the VA needs to be much better about. And if the VA is going to refer somebody, it should be a pledge, it should be a requirement that the records that that patient goes with are handed to that VA patient before they leave, period. Because I can't count on them coming to me. So thank you for that, Mr. Chairman. I'll yield back.